Hobson City, Alabama. The term city used loosely, it's really a small town. Population about 800.
We're a small community, small enough to know everybody and everybody's cat.
Hobson City's mayor says small enough to know that when it comes to trusting in a COVID-19 vaccine, many people here feel the way she does.
I'm reluctant to take the vaccine.
Wait, you yourself are reluctant to take
I am reluctant.
Most of those who live in Hobson City are African American. Distrust of the medical community runs deep. The town, located about 100 miles from Tuskegee, Alabama, home to one of the darkest chapters in American medical history. In the 1930s, government doctors conducted experiments on black men, leaving them untreated for syphilis until the 1970s, so doctors could monitor how it affected them. Alabama is taking a beating from the coronavirus, the state's 14-day positivity rate at just over 29%. In Calhoun County, where Hobson City sits, the rate is 37%. Still, older residents such as Joe Cunningham have such little faith in doctors, he was reluctant to go in for a COVID-19 test, and any discussion about a vaccine is off the table.
I was afraid to take the test.
Why not, Mr. Cunningham?
I don't know. I just don't understand it. I'd like to know where it's coming from.
I'm going to have to convince my father because he don't know what this vaccine is about. But as black people, that's all we know is to trust the Lord and trust God. We'll have to convince our family that this is the right thing to do because this will help slow it down and help us to survive.
Distrust in communities of color is not just a small-town problem, it's nationwide. A study conducted in September exploring the issue in Black and Latino communities found just 14% of Black people and only 34% of Latinos trust a vaccine will be safe.
It's almost to me like a fear. Like I have a phobia of needles. I'm almost at that point where I have a phobia of doctors.
Carmen Bailey was diagnosed with COVID-19 in April. Bailey says she avoided medical help because she feels she has been poorly treated by doctors in the past. Now the grandmother of 3 suffers from adverse effects with her heart, lungs, and kidneys.
Some days I can barely walk, and I'm tired of hurting. I don't know what to do.
What she will not do is take a vaccine.
We don't know any kind of side effects from them. So I just really feel like at this point where it's people that's going to take that vaccine as guinea pigs.
You really think they're guinea pigs?
I do. I just feel like we don't know enough.
Welcome back, global citizens. I am Pharaoh, and this is my podcast, Stay Woke. Thank you guys so much for rocking out with us the entire 2020 year. I am so honored to have Dr. Chris Watts with us today to speak on the current coronavirus situation. This is a follow-up to Vaccine or Not podcast. We had part 1 and part 2 where we discussed how vaccines are developed, how they're subsequently approved and then distributed. Now that we have vaccines that are available, I really wanted to have a one-on-one directly with Dr. Watts about our community, the Black and Brown community, questions that we have in that community, and his insight into there. So without further ado, I want to jump on and say, Dr. Watts, thank you so much for joining me today. Really appreciate, because I know you're probably on the front lines doing lots of work. So I want to thank you in, up front to say that, I can't even imagine what you see on a day-to-day basis. So I really want to give our audience an opportunity firsthand for you to share some of the issues that you have. And then the next thing following this one-on-one is that, you agreed to do a panel discussion with a group of members of our community, which I think is also important to address their questions directly. So let me just jump right in and to say, can you just introduce yourself and tell me a little bit about your credentials, where you did your schooling at, and then why did you become a doctor?
Absolutely. First, let me just say I really appreciate the opportunity to come on and be able to have some of these discussions with you and your very esteemed podcast. And so I really appreciate that opportunity.
Yeah, thank you, man.
Well, so for me, I am from a little small town in South Carolina. It's called Sherrall, and was fortunate enough to, be in an environment that allowed me to sort of figure out what I wanted to do instead of a lot of folks that are in the situation that I came from, figuring out what they have to do.
Sure.
And so one of the things that struck me as important when I was a little kid was, my dad he had a cancer. He had colon cancer. He's since passed on. Well, I just remember the frustration and the hopelessness that I felt, not understanding what he was going through, and then having to face the prospect of not having the primary breadwinner.
Sure.
And so I wanted to get an idea about how I could not control that, but how I could at least understand it and benefit him. And to that end, that would have given me some type of control, even though those things obviously you don't have any control over. So
Sure.
what happened was, when I was fortunate enough to get into college, I realized that it was not that you had to be smart, you just had to work hard. And one of the things that I've always had good examples of, folks is working hard. So I worked as hard as I could, and I ended up with pretty good GPA. And I said, well, if it's just a matter of me, studying hard, then I'm gonna go as far as I can.
I can do that, right?
Yeah, I can do that. So long way away, long around away for me to just say is just about personal issues with family and understanding things, and wanting to have a better grasp and want to be able to help people in the same situation. So that's why. And I was fortunate enough to get into a bachelor's program at the College of Charleston in Charleston. Did my time there, so to speak.
Okay.
Went on to,
metaphorically, right.
Right. Very, very similar though.
You found out the doctor now got a little felony on your record, no?
Oh yeah, no felonies, no convictions. Yeah.
No, understood.
But I have no problem with those who do. But what
Absolutely.
I would say, yeah, absolutely. So I then went to Medical University of South Carolina. I was fortunate enough to get into the program there for med school, and went to University of South Florida down in Tampa for my residency. I did internal medicine down there, and then I was once again very fortunate throughout my life. I was able to get into one of the premier infectious disease programs at Medical College.
How did you choose infectious disease? Why did you choose infectious disease, and how did you choose it?
So when I was sort of making these decisions, in the forefront of my mind was, okay, lifestyle. Or, how am I going to make sure, I had a wife at the time, and we were pretty serious, want to start a family. So lifestyle was at the forefront. And then somewhere, maybe 1A, 1B was wanting to help my people. And at that time, the biggest thing was HIV. And HIV was sort of the scourge of our community. And say, well, can I have a good lifestyle? And then can I also help folks? And that was a perfect fit for infectious disease. Plus, there was a couple of brothers at the time that were also infectious disease, was able to help me quite a bit figure out,
perfect scenario, right? You already had the situation set up where you said, but I think, to me, it seems like a complicated field, but to have other brothers in a sense to help you out, I think, and then we'll get to that piece in terms of our community too, but go ahead.
Yeah. So I, was able to talk to some folks, get some experience, rotate through, and got into the program. And so from there, it's been sort of, great, and it's one of the best experiences I've ever had in all those places. And so was.
You've been an infectious disease doctor currently for how many years now?
Yeah. So I've been doing ID in Georgia for about 11 years.
Oh, yeah. Decade plus.
So we're practicing technically after medical school. So, but the specific infectious disease part's been about that long.
Specialist piece, right? Which is important, I believe, when people are trying to make the distinction. Now, not to discredit any other doctors, but what the social media, what our news are showing when the president gets up, and this, not to discount any other medical doctor, but when you get up and you put a radiologist and you speak to infectious disease over a person like Dr. Fauci, I think it lends less credibility to the mixing of politics and science and to see how things go forward. But we'll address that later on too, though.
Absolutely. Yeah, man. So after Milwaukee, which was fantastic, I love Milwaukee. I wanted to get back closer. My family was still in South Carolina, and if you're gonna live in the South and you want to live in a city, Atlanta's pretty much it. To be honest with you. So that's how I got here, man.
And what population of African Americans is in Atlanta? Like 80%.
Well, so it's probably looking at around 70% in the downtown kind of area, what they call inside the perimeter.
Okay.
But it's definitely heavy. And then obviously once you go outside the perimeter, even close to the perimeter, it's 285 that circles it. Once you go outside of that, it's just like anywhere else in the South. And so it kind of balances out. But, you can go, I'm sure you can go all day and just us. Banks, restaurants. It depends on where you are, obviously.
Right.
But it was a welcome change for me.
So the majority of your patients are Black and brown, or a mixture of everyone?
Yeah. So I go quite a few places, but the majority of my clinic patients. So I do inpatient hospital visits as well as clinic, and then I have a couple of other things, wound centers, a couple of other things. But the mainstay of my clinic population, which is sort of outpatient visits, is probably about 50-50 from where I am. So I'm in Douglas, which is it's also majority African American or Black. But
so you have direct experience working in the field with community of color, Black and brown individuals.
Oh, absolutely. Okay. Yeah, that's par for the course for Atlanta. Inpatient is probably a little bit more African American than where I am, but obviously it depends on which hospital you go to.
All right, enough of the softball questions. It's time to get to the meat. This is where shit needs to get spicy, right? So, first question: how would you characterize the service the healthcare system is providing to Black and brown communities across the country? Below standard, standard, exceptional, and why?
Yeah. So it would be impossible to have a sort of blanket characterization of healthcare as it poses to African Americans. So that would be tough. But what I can do is needle down into some of the specifics. And so not my opinion. My opinion probably would matter very little. But what we do know is a matter of fact is that African Americans, the treatment is different. So if you look at infant mortality, for example, so when a mother has a child, the rate at which that child is able to live up to 1 to 2 years, or whether that patient passes or whether that child passes away, is much higher in our community as opposed to other ones. And these are hospital factors. These are factors that are associated with obstetrician and gynecologic service. So this is not my opinion. These are facts, and these are data sets that are readily available.
So what criteria condition are you rating that by in terms of service? Right.
Well, so
besides just the mortality rate, is what services provided that you think makes the distinction between what you provide to maybe other communities and community of color that you feel is lacking?
Right. We'll get there. I promise.
Okay.
So there are a lot of data.
I don't want you to be giving our audience this high technical talk, right? They don't want to know like what
I'm gonna get there. I promise. I promise.
Okay.
Yes, sir. So I'm just giving you metrics because my opinion doesn't matter. It matters what we can prove. Right?
It matters, though. That's right. This is what I want to speak to.
Absolutely. And so if you look at African Americans across the nation, there's a really big study that residents, so when I was at University of South Florida, that's what I was. So residents, people that are primarily in training for being doctors, they believe that African Americans feel pain less often as compared to white.
They feel pain less often.
Feel pain less often, or their pain and their pain is less severe. So it's not my opinion. This is a well-published study.
Right.
And so
why? Because we tolerated slavery so long that made us be pain resistant somehow.
So we can't necessarily glean the motivation for some people's thoughts. But what I can tell you is it's been well established that Black people are viewed differently. Our children are thought to be older than the same children in other communities at 10 or 12 years old. Okay. So we are viewed in this system a lot different, and the healthcare field cannot be it can't be separate from that fact. Everybody is a member of this society, and I think all those things sort of trickle down. But to
Okay.
answer your question, I can go on many studies that talk about the disparity between African American community and other communities with regard to healthcare. So that has
Okay.
been well established. Now, the reason and the cause and what we can do about it is a little bit more tricky. The reason is multifactorial. So you can say, well, in our community, we have higher rates of, let's say, cardiovascular disease, diabetes, et cetera. Now, it would be remiss to just say that that's the healthcare field's issue, but we can say there are legitimate issues that can be addressed. One is we can have education about the fact that there are basically very little differences in the way that we feel pain. And so what happens as a result of a clinician thinking that an African American feels pain less, when you call them in the middle of the night after you've had your baby, they're
Right.
less likely to take that thing serious. Okay, and that's from a personal standpoint and others. Serena Williams, for example.
Let's go back before you give me any more things. I'm sorry to interrupt you, but let's go back because I think we're touching on a key point. I want to know how did medical professionals get to the final summation that African Americans feel less pain?
Right. So that study did not seek to determine why they felt that way. That study was a focus on trying to determine if that is indeed a fact, because it was something that was believed for quite some time, but there was no data to say, yes, that is indeed true. Now we know that it is indeed true. Now, the research community
meaning what's true is that you have individuals in the medical profession who treat our population who feel, right? So, I mean, was a feel-good survey.
No, sir, not a survey. This was a trial. This was a legitimate trial that was powered to be able to make these conclusions. And so what the conclusion was that there are residents, the majority of white residents, a plurality of white residents believe, and some black residents believe that African Americans feel pain less than their counterparts. That's the only conclusion that was made from that study. But you can extrapolate why maternal fetal mortality is high, or in other words, why when we go to have our babies, why our babies die, and why we have more complications than others. Because one of the reasons, just one, not all, but one of the reasons, when we call, they view our pain as less. Okay, so they're less likely to take actions to prevent whatever negative outcome, whether that's hemorrhage, bleeding, whether that's other fetal complications. And so,
what about parents? And I'm sorry, what about mothers, like during the course of their pregnancies?
Well,
in terms of treatment, like prenatal vitamins, like checkups regularly, the exercise, diet.
Right. So there's less and less. So there's less prenatal care because obviously we have less insurance.
Okay.
So the situation when you come to the physician, you're already a little bit in the negative because you had less prenatal vitamins, for example. Your nutrition is not as good. Your exercise wasn't as good. Your access to healthy foods wasn't as good. So all those environmental, socioeconomic things are still there. Right, and then you present, and then after you have the baby, or even then, when you see the doctor, he or she has a perception about you that is different from your cohort. So you're struggling when you walk through the door, and then when you get through the door, you still behind the 8 ball. And because of those things combined is a reason. It's not necessarily just the community; it is the system that we live in. And so it's just a byproduct of that. But
let me qualify my question in regards to characterizing the service. I want to know in reference to geographic areas that have larger populations of African Americans. Are the studies then looked at in those areas in the healthcare fields in respect to the areas that have these populations? Is that study done with that in mind?
So let me make sure I'm understanding right. So you're asking me
meaning I say if we're 13% of the population, right, or 13 or 14% of 330 million, so out of 40 million blacks, where are we concentrated? Where are we concentrated at in the country? Like what cities, right?
Yeah. So
Right.
in
And in those
states,
and in those cities that provide healthcare, my question is around how is the healthcare system characterized in those areas? Now I know we're sprinkled throughout the country, no doubt.
right.
But my question is more characterizing the healthcare services where we have larger populations of African Americans.
Yeah, yeah, that's a good point. So if you look at where most of us live, so there are more black people in Mississippi, for example, than anywhere else,
Okay.
percentage-wise, right?
Okay.
And so you have multiple factors that take place. So if you look at a hospital in rural Mississippi that caters to a predominantly African American population, the amount of
Okay.
the level of care there is likely to be commensurate with the level of care all of Mississippi, maybe a little bit lower. So it's not going to be the same thing as in Connecticut, for example.
Okay.
But if you look at that in like South Atlanta, right, there are hospitals in South Atlanta that cater to a very a prominent African American community, and they will be as good as anybody in the country. So it really depends. The socioeconomics plays a lot into it. So the amount of funding, the amount of tax base that a community has, and I can't say that breaks down just along lines of color. But if more of you are in a lower socioeconomic level, then it affects you disproportionately. And so that's a phenomenon that we've always succumbed to. So you don't have to necessarily do it because you're black, but if you get most of the poor population, it'll get most of us.
Okay, so we did part of the why. I still want an answer out of the below standard, standard, and exceptional in the geographic areas that have larger populations of African Americans. Just your opinion.
Yeah. So if I were to give my opinion, what I would say is that if it's a lower socioeconomic level, and that is like let's say a town or a city,
I see.
it is likely to be a little bit lower. But there are examples where that's not the case, and there are efforts to standardize things. So it's very hard for me to say whether it will be substandard or above standard because they're really good examples.
I'm going to ask you to speak to later on. You can address it however you want to. If there's any kind of effort to standardize the care independent of socioeconomic area or geographic locations, right?
Absolutely.
In that sense, across the medical community. All right, let's jump to number 2. What level of responsibility do Black and brown folk have to champion their own health care? And there's multiple parts to this. What diseases disproportionately affect our communities and why, pre-existing conditions, and what should our community be doing to live better? So first, what level of responsibility do Black and brown folks have to champion their own health care, and what kind of guidance would you provide?
Right. So this always begs the question of personal responsibility versus responsibility of the community. That's really what you're asking. And what I would say is Black folks have been, and other folks have been able to
or even individualize it, right? Don't make it about communities. I think if we individualize it, we live in the community by default. Everybody's working toward the same objective in a sense. Right.
Yeah. So if you say to me that so to answer your question, if you have a situation where you are just responsible for it's a little bit tough. The way that I would answer it is this. It's tough. We can achieve in despite of incredible odds against us. And that is the extent to which I believe people have a personal responsibility. You have a personal responsibility because your health and your body is probably the most important thing that you own. It's the best.
Right. I'm not talking about that, right? I'm not trying to give people a job, but I'm saying if I'm going to say my first question surrounded the healthcare system. My second question is more to your personal responsibility that, balance with the healthcare system that may be set up against me, may not be the greatest, then personally.
I got you. Yeah, I think I understand what you're saying.
Okay.
So, but my point is this. My point is that you definitely have a personal responsibility, but you have to understand that personal responsibility in the context of larger things. You can't just say, okay, well, Johnny has to make sure Johnny's healthy and Johnny doesn't have money. Johnny doesn't have a way to get anything. Johnny doesn't have access to information. Okay. So we can still accomplish things, whether you're talking about academics, food, you're talking about health, and despite all the obstacles against us. And I think that's our task to do that. that. We have to continue to do that. The way that you do that, though, is you have to make sure that, one, you are aware of all the external forces that are against you, and at the same time understand that you can achieve. The way that you do that is with information. With information and motivation, and it's a cycle. So we now know that probably 60 to 70% of the population of the United States is vitamin D deficient, for example. Just an example. What does vitamin D do? So vitamin D is associated with depression. Vitamin D is associated with your energy level. Vitamin D is associated with your cognitive ability. We now even know that vitamin D is important for COVID protection. And so if you understand that vitamin D is more of a steroid, more of a hormone than it is necessarily a vitamin, you understand how important that is, you're more likely to be able to access that vitamin D, ask for that vitamin D, and get that vitamin D, just as an example. And so that's one way that you can sort of overcome some of the pressures that sort of prevent people from.
Let's get back to the point you touched on, which was really important. I'm sorry to interrupt you again, but I think that you hit on very key thing: information. Our sources of information. How do we assure ourselves that one, what level of responsibility? This is probably changing the question some, but this is what I do. But
that's it.
Right. So what part? What part of the information that's going to be shared? How much responsibility does the government, does the medical community have to assure that African Americans have an avenue to get the information in a concise, educated, accurate way, when there's so much misinformation on news that's being presented that's confusing the lay person that's trying to distinguish all the things that are out there? Yes, I have this responsibility, but in the absence of having clear direction and information, I'm going to default to what I do best, which is probably nothing or whatever people locally do in our environment, right? I'm just keeping it 100, right? Yeah. So where's that gap bridge where we provide, and this is knowing your community, right? Well enough, there is a gap between science, medicine, what we need to be doing to educate ourselves, and then how that information is shared to a targeted community.
Absolutely. And so the way that you do it, so the responsibility, as you mentioned, as you so well articulate, is everybody. Okay, my worldview, I could sit here and try to talk to you about what is personal responsibility versus responsibility of the government, et cetera. But my view is it has to be a community. So it has to be a global sort of effort. My thrust is making sure that we're sort of healthy as a people. And as such, the best way that I've seen throughout history to do that is if it's a community approach, which means that, you can't isolate one part of it from another. I am my brother's keeper. So it is absolutely a important and critical factor that people have the right information, people have the right access to information. And it is a failure in our local and federal governments that is not the case. Examples are like internet. Mostly, a lot of homes don't have internet access. Right. The schools are subpar. Okay, and then you look at the access to the things that they would realize they needed if they had access to the information.
So what do? We default to Twitter and IG and conspiracy theories, right? Because that's where we collectively have that information shared. I'm just thinking, how does our community become more savvy at using the tools that we know that the community connects more with and will less likely do? So I mentioned the CDC, the WHO, the New England, Journal of Medicine, the American Medical Association, the FDA. I mention those all the time, but it's how likely are we to traverse that website, look for the pertinent information that we need and gain it, even if it's public information? How that gap that we make it?
Yeah. So what you see is change, and you see people like my brother Pharaoh with his podcast. You see other people that are disseminating information, and I have to be honest with you, you are seeing things move the needle a little bit. I'll give you a couple of examples. 15 years ago, so you look at athletics and entertainment. Those are the people who the young folks look at and say, "Oh, I want to do what they're doing." Okay, so why now does Beyonce look like she's 18 years old? Beyonce's eating a plant-based diet. Okay. And Jay-Z's secondarily quasi eating a plant-based diet. And she's talking about those things. Why is LeBron able to play for 36 years now at the level LeBron's eating the plant-based diet now. LeBron's taking care of his body and talking about those things. Not only is he doing that, but he's going into schools and developing schools. Other people are doing these types of things. So if you look at athletics, you look at sports, the way that we thrive is only one way. It's the way that people have thrived for thousands of years, and it's the way that is sort of the most holistic. And when examples start coming out saying, this is what I'm doing, when Brother Pharaoh starts coming out, say, this is where you need to get your information, this is what you need to be doing. When it surrounds people, they have examples and they have access. I think the way that you're doing it now, and Facebook and all those things are very important, especially for the younger generation. But I see some movement of the needle. I mean, we want to say how tough things are, but we also have to acknowledge when things are getting better. For example,
I was going to ask you that too, because we, not that we like to complain, but we like to complain, right?
Yes, right.
But I think there's
justifiably so.
right. And not saying it's not justifiably so, but at what point do we try to find a way to move the needle in? Although these things are happening, we have also made this level of progress with our people, and that to focus and build around and to develop that community of people that understand that. What kind of diseases disproportionately affect our communities?
Yeah, so that's an easy one. Just about all of them. And so if you're looking at cancer rates, it's unfortunate, but it's true. If you look at cancer rates, if you look at colon cancer rates, they're higher in our African-American community, which is one of the highest frequency cancers. If you look at coronary artery disease, one of the highest in our community. If you look at hypertension, if you look at obesity, if you look at coronary artery disease, if you look at cholesterol issues, those things are highest in our community. So the thing that kill people the most, colon cancers, things like lung cancers is not as bad, but colon cancers, diabetes, obesity, coronary disease, those are the killers, and they're highest all in our and disproportionately high in our communities.
What should our community be doing to live better?
Yeah, so it's diet and exercise. And right now, as you and I are talking, a year and a half ago, the Food and Drug Administration has issued guidance about what is healthy and what is not healthy. And that's not trickling down, because there is a void that you talked about a little earlier between what the science says and the implementation. Okay, so now we're still talking in our textbooks that you still have this food pyramid with this stuff on there, when the FDA has already proved and documented that the best diet for a human being is a plant-based diet and 30 minutes of exercise 3 to 6 times per week.
So we don't need meat. So you say there's nothing in meat that we need. There's no protein, iron, other stuff that we can't get. Or you're saying that it's healthier to get those same minerals and vitamins from other food sources.
Right. I'm saying,
because I don't eat pork or beef, right? I don't eat pork or beef, but I love some chicken, turkey, and fish. Right. I'll be 54 years old next year, right? So that's my thing. But I've not given up meat in that sense. Are you saying that I really don't need that, and I could really curb and extend my life more if I ate maybe a plant-based diet? Because
right. So what we're talking about,
some people love a steak, right? You look at people, how you get them out of a steak? I mean, but maybe
no doubt about it.
Or is it proportions? Or do I need to talk to you?
Yeah, so I eat meat from time to time myself. So when we talk about plant-based diet, we're talking about plant more often than meat. So and that is sort of one of the ways you get there. One of the things you believe in a community-based idea is, don't beat yourself up, progress in the right direction, but don't kill yourself when you make mistakes, right? So the strict data is, they looked at this very closely. The biggest study on longevity, one of the biggest studies in the history of humankind, was something called the China study. Right? And what did they do? What they did was they looked at hundreds of thousands of people, and they looked at these, what they call blue zones. You might have seen some of the documentaries that have subsequently come out of this effort, where people live to consistently be 80 years old, 90 years old. Yeah, and what they found in those, right? And what they found in those clades of individuals, those areas of individuals, was that they had a plant-based diet, predominantly plants. They exercised. They walked pretty much everywhere they went. They did things like meditation. But as far as their health is concerned, there was significant data to suggest you can even reverse, certainly halt coronary artery disease just by using a plant-based diet. Wow. Now, the extent to which you do that is an individual choice. But the information is important. Having the information saying, hey, look, this is what can make me better. This is what can make my diabetes better. This can help prevent coronary disease. Things like impotence are strongly related to coronary artery disease. So that's big in our community. So what I would say is those.
But we made the blue pill though, so it don't matter.
Well, that blue pill don't work. So that headache kill them.
Okay.
But to answer your question, it's
Yes.
it's not an all or none, and I'm not talking about veganism, right? So
Okay.
I'm not talking about 100%. I'm talking about moving
A
in the direction of
plant-based
more
diet.
plant.
Okay.
Yeah, moving
Okay.
in that direction will make huge inroads. And this is not me. This is the data, and this is now the government. By the time the government says something,
Right.
it's been
It's way too
co-signed.
late, right? That story's already
Right, right,
taken off. But I
right.
think the message, though, should somehow trickle down in programs that really target our communities if we want to make a definitive change, right? A change. The information's been for a while. The reason why I started the podcast, because there's no bridge between that information that's completely fucking boring and people don't want to hear or listen to, but absolutely necessary and needed. So we complain about the things that happen to us, but the methodology in which we shared that we resist this, because we need to have it some kind of way. If it isn't given to us like lit, and if it isn't hyped and pumped, we don't really want it, right? But I think even that being so, that's just the culture. So I'm looking at responsibility among our government and medical professionals that find that way to bridge that gap with different communities. Let's go into the third question. Do you believe this was a pandemic to depopulate the planet with a specific emphasis on killing Black and brown folks? If not, why? If yes, why?
I do not. And a lot of reasons why. One of which is because it does not. If it was, it would not be. So if I'm a guy, just having a little bit of infectious disease background, and I say, okay, well, if I want to get something that's going to depopulate,
or say you're the government. Let's go even further. I want to take it to all the way to conspiracy. Say I'm the white controlled government. Right. Because this is the thought process, and I want you to address this clearly. And I see where you're going with the logic. A white-controlled systemic government that has racism throughout this entire thing. People have experienced all this. That's what we think. So when something comes out like this, the government is trying to kill us.
Right. So if they were, it's actually killing more whites than it is blacks.
Okay.
I don't necessarily believe that the government's in the business of getting rid of population. So it's kind of hard for me to start there. But if I was a government and I was in the business of trying to depopulate folks, I would get something that's a little bit more effective than COVID. Because if it is, it's not very good attempt.
It's the worst plan they ever could have devised.
It's the worst plan as ever. And there's many, many more pathogens that I am very aware of that would be more effective in doing that.
Okay.
It is a lot more difficult to carve out African Americans from the general population if you wanted to target them. The way that you would do that is you would do that with socioeconomics, right?
Okay.
So I don't need to, and if I'm a conspiracy theorist, which I'm not an extreme conspiracy theorist, but some things merit legitimate consideration. If I was, though, what I would say is that in this country, if you're a capitalist, if you are the whatever you want to call them that are controlling whatever, what you would want as an ideal situation is to have a person do what you want them to do without asking them or without forcing them.
Okay.
And I see a situation when I turn on television and when I walk around some places, I see that is indeed going on. We spend as a community, we spend 110% of what we make. So why do I need to get rid of somebody who's giving me everything they have? So you're giving me 80 hours a week.
I'm cutting off my revenue.
Right. Yeah, you're giving you 80 weeks of your labor, and then when I pay you for said little bit of labor, you giving that all back to me.
Right. And why would I want to kill that source if it's going to be a plot? But that doesn't make sense to kill. Okay.
It just doesn't make sense. It doesn't make sense. Why would you want to cut your hand off? Because I don't want, if I was in charge, I wouldn't want to put in that $80 a week at whatever factory or hospital like me working. And I include me in that labor, giving that labor away. Although I do try to keep my money in the community as much as I can.
Okay.
But yeah, so there would be no motive for that. The real conspiracy is that we are essentially giving up what is most important, which is our time for something that may not benefit us. That's the real conspiracy. Yeah.
Does the government control science?
Wow, control science. What I would say is that
if it's the scientific activity going on, right? How much does the government play into the information that's shared, the path that's done to make sure, right? Because I think the idea when Trump was up, really sharing information about it, he had Dr. Fauci, who I think pretty much was very clear most of the time he got up. There was some political jargon utilized in pieces of it, but what that does, that causes an essential distrust amongst the general populace because they feel that government has had some kind of influence on medical development and then subsequently on how that information is shared.
Well, some of the most important developments in the history of medicine in this country have been government-funded research. So the government, first of all, there's a couple of things that I want to say. One, there's no such thing as the government. We are the government. You and I make up the government, and so this idea that we have allowed to be established that there's some government and then there's us. It prevents us from being able to participate in the government like we probably should. So that's the first thing I want to say. The second thing is they're supposed to function as an independent sort of referee whenever there's things going bad. They've got groups, FDA, they've got offshoots. It's not CDC, is not a government organization, but they work very closely. And then there is a whole observation arm. There's the NIH. There's a lot of functions that the government serves. The VA does fantastic work. So some of the research is certainly impacting. They also set some of the standards, right? So I can't do certain studies in the United States because of governmental laws and governmental policy.
That's what I was going to ask you now. What measures are in place to protect the general public?
Right. So you cannot. So the reason that the reason that you, not you, Brother Farrell, but the reason that the average person knows that there's a phase 1 and phase 2 is because our government and other governments have established those as a framework to be able to make sure that, one, you don't start off killing people when you try to get a drug intervention, right?
Even though, but our history, right, has some, I mean, I have to lend some credibility to our history, right, which has then propagated maybe some conspiracies, like, I'm sure you're familiar of the Cutter incident.
Yeah.
Right?
Yeah.
And right, just, okay, go ahead.
Absolutely. So the reason you know that is because there are efforts. There's a framework that's been established by the scientific community in conjunction with not just our government, multiple governments, to try to limit the risk of you having major issues to people, but also at the same time understanding by the time you get to a phase 3 trial, there are potentially going to be some untoward side effects from whatever intervention, was a medicine or a procedure, and that's why you sign a consent when you do that. You also have to be an advocate.
So full disclosure in a sense, right? Which I don't know. And full disclosure, consent, controlled protocols, those things were, I don't think existed like years back, or I don't know how many years back before they had,
Well, there have been some people sued. So all of my life, consent's been here, right?
Okay.
And I'm not sure when exactly it started. I know that. So for example, most of the most of the procedures that they do on women when they're having babies were designed by a guy, predominantly in Louisiana and other places, and he didn't get consent from slaves and African Americans at the time to do those. Sometimes they didn't even have anesthesia. So there's certain periods in time when that wasn't the case, but most of my lifetime you do have to get consent.
And that's the point that's really important to make, that people may have heard, but I want to put it in context of time period, that science evolves, medicine evolves over a period of time, and we learn, unfortunately, sometimes it's from mistakes and death, but that allows us to put protocols and measures in place to protect the general public. Question number 4, is the coronavirus man-made, and are there other variations of the virus that may come down the line that may be detrimental to us?
Yeah. So it does not appear that it was man-made. The suggestion here was that there was a lab in Wuhan that was developing similar virologic viruses, and could some of that have been released by mistake and caused this epidemic? What I would say is that there's no way for me or anybody else to be able to verify it. But what I do know that several governments, more impartial, Japan, I'm pretty sure Australia and a couple other governments looked at that specifically, and their conclusions was what their conclusion at that time was that this was not the case, that it was not something that was man-made. But there's no way for me to say with any high degree of certainty based on science, because nobody except those countries I talked to looked at that. I don't believe that that was the case. But I can't say with certainty that it wasn't, but I don't believe so.
Where do viruses come from?
So viruses, so if you talk about, so viruses come from many, many places, but mostly a virus is just a coat of proteins and either RNA or DNA and maybe some other things.
Right.
They have always been around, and they were around before, if you believe in evolution,
I
before
do.
us. And if you don't, they were still around way, way before. So viruses kind of always been around, and they change from time to time. There are viruses, for example, in the permanent frost in Antarctica that we have never seen before prior to climate change. Now, who knows what that stuff is going to end up being for us. But every year, an influenza virus, just an example of how this thing evolves, comes from Asia, and it comes towards this direction. That's how we know how to make the vaccine. It's based on what virus is in Asia. Now, sometimes we get it right, sometimes we get it wrong. Most of the time, it's somewhere in the middle.
Okay.
But I say all that to say that the virus circulate in our biosphere. In the human population, every single year, there's always new viruses, and some come and some go. But they've always been around, and I don't imagine we're going to be able to get rid of them. And some of them do very important things for us. So it's not like all of our microbes are insignificant. Because,
sure. And before we didn't know about microbes, right? Before then, people were dying, right? Before we knew about germs, funguses, viruses, and bacteria, like we were just, probably doing open heart surgery right there in the middle of the garage, somewhere where it wasn't in a sterile environment.
Yeah. Well, someday you and I will have we can maybe have a discussion about what most folks would call prehistoric medicine, in which case there was awareness. Yeah, there was an awareness.
Is that the term used? That's what they call it, prehistoric.
Right. So there was an awareness of things like bacteria, and there was awareness of the anatomy that was somehow lost, and now we're sort of catching up. So that's
right.
worth
I think we take that for granted now that it was obvious at that time, but it wasn't. Right. So some of the things we did then probably be horrific to people right now.
Just let me give you an example. So there was a tribe in East Africa. There was I believe it was a Dutch physician who went there, and I'm believing this was around 1600, but I'm gonna have to check my dates. He went down to Africa, and I believe it was in West Africa, and he witnessed Africans performing cesarean sections with no pain, with no anesthesia, and almost 100% success rate.
Wow.
Okay. And so there's a lot of knowledge that was there and has subsequently been lost. And now, Western medicine is kind of catching up, I believe. But there are a lot of examples of that. We can talk about that all day.
Okay. Deforestation, the Amazon, as the population continues to grow and we encroach on areas that we haven't, do you think that could be adding to the release of viruses in our environment?
Oh, absolutely. Not just viruses, but there are bacteria in certain areas in the Arctic that have been identified that we have no idea what they do or what they could potentially do or never seen before. That is a fact that we will be looking at diseases that we have no history of and potentially no way to treat. That was one of the reasons why your brother Obama instituted or started the committee to react to global pandemics.
Right, absolutely.
And that's also one of the reasons why your president decided to disband.
Oh, he's my president now. Right? Well, I'm going to put an ex-president in front of that, right?
Right.
And I'm really hoping he resists leaving on the 20th so I can watch the CIA do an activity of dragging his ass out. I'm just my own visual. So, zoonotic spillover. What is that?
So what you're talking about what happens when there is a virus or a pathogen that is native to a non-human species that then jumps over into human contractility. And there are theories about some animals in the Wuhan area that were associated with that with COVID. It's been theorized many times, and it has happened many times. HIV is one that may have come from something called a simian immune deficiency syndrome, which is associated with monkeys. Fish and poultry are very common pathogens that result in human transfer. I'm sure everybody remembers what was that? The swine flu.
Yeah.
And there's been other murine.
That really wasn't from the swine, though, right? It wasn't
nothing
really
to do with the swine. Yeah, I don't know how I got that name.
I forgot the story, but I think I forgot how they got the name. But I forgot how I got. Yeah, but it wasn't the swine flu, right? Like the Spanish flu didn't really originate with the Spanish. Right. It was just the king got it, and then England, I think, began to start, putting out information. But I think American soldiers, right? American soldiers brought it from here in World War I over to France and end up having a global pandemic. So, I think,
and the reason, as to your point, the reason they call it Spanish flu because they were one of the only countries that were actually letting their people know the actual infection and death rates.
Right.
The reason it's not the American flu is because we were hiding it.
Yeah, Woodrow Wilson was hiding because he wanted people still to go and volunteer for the war, even though people were getting sick, which is so reminiscent of what we're doing today. Imagine that, right? That whole scenario, the Spanish flu, people were anti-mask, they were in the streets, they were protesting their rights and freedom. And he was suppressing the information specifically so that people can continue to volunteer for the war. Last question. Did you take the vaccine and why?
Yeah, so if I can, let me just give a couple of minutes on this because this is very important.
Yes, okay.
So,
or will you be taking it?
Yes, sir. So I had a natural skepticism when I first heard that they were going to have a vaccine in a short period of time. And I also had a natural skepticism when I realized the people that were driving at least the implementation of the rollout were the same people that talked about there's good people in West Virginia riots, and so I had a very high level of skepticism about whether that would be something that would be good for me. When I looked down at the information a lot closer, I realized, one, that this vaccine was something that was developed by a completely different company, the Pfizer one. The second vaccine, Moderna, the lead investigator is a sister, and not just a sister in name, a real sister.
Okay.
I don't want to get into culture politics. I'm not saying some are not, some are.
You already said right there. You made the distinction there.
I'm just saying that I like her. I will
efforts and deeds, maybe by efforts and deeds, not necessarily by color or hue. Right?
Yes, sir. Yes, sir. And so, and some of the other ones are very good science. And then I needled down and said, okay, well, I'm going to look at the data. I'm going to look at every single word on every single document that I could. I went through that. Then I looked at the history of this technology. So the other question I had was, this is new technology. Nobody's ever done this before. Well, people have done it before. The technology was tried in even 2017. There were rabies vaccines that were RNA viruses. There was Zika virus vaccine. And so it was not something that's as new as I thought. And there were actually some studies back in 2005. And so then I had to look at, well,
it's just not widely used to make vaccines. mRNA it's a methodology that's been in the system for a while, but it's not been used necessarily to make vaccines. Well, we haven't had many pandemics.
Right. Well, there is a Zika virus.
Well, the Zika, but that somehow faded out, though. I mean, what happened with the Zika?
Yeah. So that's what I'm saying. So
Ebola, right?
Yeah, that's right. So my question was, why did those vaccines fail out? That was my question.
Okay.
Why didn't they come to and as it turns out, so I looked at those studies. The reason that they didn't proceed was because the rabies vaccine they have is fantastic. Ebola was already contained and Zika virus is contained. It wasn't because there were problems. It was because the treatment wasn't needed. Okay. And so that gave me a little bit of sense of safety. And then I looked at the data. That gave me some safety. Then
that's another question to ask you. How does this shit just die out? Right? How does Zika, Ebola, like?
So it's not died out. So when I mean died out, what I mean at enough levels to be a contagion concern. So Ebola's been here. So we learned about Ebola. Ebola was in the 50s. There was another one called the Marlboro virus. This stuff is old. This often is always smoldering somewhere.
Okay.
But Ebola, for a lot of different reasons, can never threaten the population of the world because it kills you too fast. But we can get into
Okay. No, I heard you bleed from every open orifice.
Right. That's right, Fred. So I looked at all that stuff, and then I said, well, I really searched hard. Then I talked to some people. We were actually involved in one of the studies with the Moderna.
Oh, nice, nice.
In this area.
That lends credibility, though. That's why I'm so happy I
well,
got you on, because you've been
right.
involved directly with some of that work.
Right. Well, what our physicians were. I was not personally. I did not sign anybody up personally for the Moderna vaccine, but I know the people that did.
Okay.
And so, and then I looked at, I know some people that knew the scientist that started the mRNA technology, the guy from NYU, one of the mRNA technologies. And then I talked to a lot of people in the community that looked at this stuff. And I said, okay, well, I tried really, really hard, Brother Farrell. I tried as hard as I can to find a reason why
some shit wrong with the way they developed this vaccine based upon speed, safety, and efficacy. Talk to me.
I tried it. So speed, now I realize that it's the technology. It is the technology that allows it to go faster. And that's a good thing. So so the issue of why is it so fast? I can't fault you for that. And then the issue is, well, what is the safety? Now the safety at 2 months, we have plenty of data that 4 to 8 weeks, we have that's clear. Clear as day, 30,000, 37,000 people, no problems, no major issues.
Let's talk there before you move on, because then I want to talk percentages, right? So normally I think it's 6 months that they have to have in the phase 3 trial before they start to consider the data.
It depends, but that's a good average.
Well, I'm asking it for a specific reason, because say we take 2 months and say, of course, it's understood the longer you wait, the safer it can be, right? Because the people who are already rolled in the trial do longer, right? But if you wait in the middle of a pandemic, what will happen?
Well,
if we just waited, no vaccine administered, and we waited, what would happen? I mean,
the research. What would happen is people die. The researchers.
People die, man. Let's call it what it is, right?
But I don't know if I agree with that point. I would not have taken it had it been, okay, well, we need to roll this out, and I'm worried about people dying, so let's speed it up. I don't think that phenomenon happened.
Not in the absence of safety data. Not in the absence of efficacy data, not in the absence of that. But I'm saying enough that you can talk to me about side effects, long-term effects, right? Because you can't really answer those questions. Even if the data for 2 months is safe and effective, you still can't prove to me long-term. Well, not necessarily. Well, go ahead.
Yeah. So you're talking about 37,000. So I also asked myself that question too. What about longer than 2 months?
Numbers matter.
And so the 37,000 was the 2 months, but they have data back to July. So there is a patient population that got it in July.
Okay.
July. So we have a little bit. It's just not big enough to be able to include in the FDA data. So
Understood.
we do have some evidence, and then we have people getting in the UK, people getting in, then people start getting. I know. So I said, okay, this is not too bad. I can't find a reason why not, but there's certainly a lot of reasons why I can do it.
Okay.
Why I should do it. And the biggest reason for me was I've got, 3 kids. One's 8, one's 12, one's 9, and one's 12 now, and then a 17. If you could imagine let's say my 9-year-old gets COVID, because I'm in the hospital all the time. I do take precautions, but maybe, on my clothes or whatever. Gets COVID. He goes into one of the best hospitals in Atlanta, which, obviously we live pretty close. He'd get in a good hospital. When he's sitting in that room, hypoxic with a nasal cannula in his nose, cannot breathe, I can't even be there with him. My wife and I can't be there because of the pandemic.
I know.
To me, that was a scenario that I had to do everything I can to make sure within safety that I could avoid. And so if it's me, if I go to the hospital, I'm on a whatever, I'm in the hospital, I'm good. My wife, she probably good too. Don't tell her I said that. But my boys, my little, especially my little one, can you just imagine the person you love probably, just being in a room with nurses they don't know, changing their, it's just.
And that's the last thing he or she may see. And let me just call it what it is. Right. Yes. Right? This is not one of those viruses where I can go say goodbye and I can hang out in the funeral. That might be in your last time you've seen the person. So I'm glad you led to that.
Now, one more thing. You don't do that, even though that could be a possibility. It's not about scaring. And please, if anybody's listening to this, that's not what I'm saying. Okay. What I'm saying is,
I'm saying that shit. If nothing else does it for you, I mean, risk reward.
Right,
Right,
right.
I'm
But
saying risk
what I'm
reward, but
saying is,
I'm saying you because you're a doctor, you can say that. But I'm a scientist, but I'm a scientist, a lay person in the local community, and I'm saying this for me is scary as shit.
Gary,
Right, what could happen? Because it's a one mistake not to do it could
it make all
possibly
difference.
leave me never being able to see or speak to a loved one again.
Yeah, yeah. No, that's a fact. That's a fact. And there's not like we didn't look at it safely. So I looked at it extensively. I promise anybody that's listening to this that I would not take a risk if I didn't have to. I
Okay.
would come out of if I thought that it was a big risk. I would just say, look, I can't practice for 6 months and go sit somewhere, sit down somewhere.
Right.
If I thought it was, I wouldn't expose my family because that's another option. But it wasn't that big of a risk, in my opinion. We don't know a year, 2 year. You're not going to have that information, but I felt
Okay.
safely enough about it, so I took
Okay.
it yesterday.
Okay.
So I took my vaccine yesterday. I took it right here in the arm, and it was nothing. So far, so good. Everything is fantastic. I have no concern. Nobody in our cohort, I was there. I helped sort of manage the rollout, and nobody in the whole day had any issues whatsoever.
Okay, so it's been what, 24 hours for you?
It's been 24 hours for me, but we started. Some folks got it as early as Saturday, Sunday.
Okay.
Everybody's been fine.
So
There is somebody I want to at some point I want to talk about that somebody had an issue. I know somebody's going to look at this on YouTube and find
I'm
it.
talking about side effects. That's my last question to you too. I'm right there. So I want to talk about side effects, anaphylaxis, and then end with risk versus reward. And there are a few things on there, like the UK. I think the lady that got it in UK that passed out. People want to know whether or not she's still alive. And then there are other people that have had some interactions. So talk to me about with side effects, and then at the end, anaphylaxis, long-term effects, risk reward.
Yeah, so there's been very few reported side effects. The biggest thing, and it's fairly consistent, not everybody gets it, is injection site inflammation. Or in other words, your arm is sore. Now, if you've ever had a vaccine, you know that's the case with everybody.
That's always, your arm always gets sore, right?
Right. They also had a couple of people that got some swelling in their neck, not in our situation, but in the study data. There were not any major issues that were in the group that got the vaccine higher than in the group who did not get the vaccine. So in other words, there were no major issues that were believed to be associated with this vaccine. There was nothing consistently showed other than inflammation, maybe some muscle aches, myalgias, but that is a function of the immune response. That is your body saying, I am doing what you told me to do.
So if I get chills, a headache after night, and then I get better the next day, that doesn't mean I have the virus per se, right?
You did not get the virus.
Right. That means I probably am building an immune response to the vaccine.
Yes.
Would that be
That's super important. So you are asking your body to remember this protein, so next time it's
I lost you here for a minute.
We can react faster. The way
Say it one more time, because I think your screen froze, and I think that was vitally important that you share that last point.
Okay, so what you're doing when you get a vaccine is you're asking your body, you're saying, body, remember this, so the next time you see the real deal, you can react faster.
Right.
And in remembering this, the scenario that memory process is similar to the actual one when you get the infection. It has to be. And so there has to be some symptoms, whether those symptoms are minuscule as, injection site reaction or pain at the site. Sometimes you get 1 to 2 days of just feeling a little poor, not like a virus poor, obviously not, but something maybe 10% of that. And that is the best. That is your body saying, you asked me to do something and I'm doing it.
So as a scientist, this is why I believe in the messenger RNA a little bit, because when I looked at, and when I was really trying to gauge whether the technology was solid, independent of the company that did it, was the efficacy. They both got greater than about 95% efficacy, which to me speaks to the technology itself. And that as viruses mutate, the ability to actually remake a new vaccine is much easier with this newer technology if you have levels of mutation. Why do we have to get the flu shot every year?
Yeah, so without going too much into it, there's cell markers, or there's viral markers that are on, and you direct your vaccine at those markers. There's a hexosaminidase and neuraminidase. That's when you get the N and the 1 and the H1. But long story short, that every year the virus changes a little bit, and if it's a different virus, if it's a different virus, then we have to make a different memory for it. And so that specific virus changes a lot more than some other viruses. So influenza changed a lot. We don't know what COVID is going to do.
That was my next question to you. Would you see this in long term year that I may have to get multiple or a yearly COVID vaccine?
Yeah. So there's other coronaviruses that we try to take example from. One of those is every year one came and went, never seen again. So we will have to wait to see if this is something that will be a yearly sort of situation or not. It's less likely to be a yearly, but that information we'll have to wait and see.
Dr. Watts, we're coming up on the hour. I want you to leave. You had one lasting key message to leave to Black and brown communities, people who believe in the conspiracy theories, doubts about this current coronavirus vaccine. What other method, what other way are we going to come out of this if we don't take the vaccine? Or what do you want to share or say to the people in closing that you really want to communicate to the people who will be watching this this podcast?
Right. One of the ways that you can do it is this. Most of us have a car, especially in LA. All you guys have cars, but you trust that car with your life, right? So if something's going on with that car, you could potentially crash and die. So you trust a mechanic at some facility to be able to fix your car such that you can trust your whole family with it. Okay. Same way you do that, you have to have an individual in your community, in your friend zone, that you trust who is legitimate enough to be able to know this stuff, whether that's a doctor or whomever. You have to find somebody that you trust that can do this if you're not in the business yourself, whatever the endeavor is, medicine or whatever. But if you don't have somebody in your network, a physician that you go to, maybe your primary care, and trust an individual. Sure. If you don't trust an individual, you need to get another physician. You need to find a physician that you trust.
And you don't have to stick with the physician that you have, right? Because it's assigned to you. Find someone you can communicate with.
That's right.
Right?
You need to
honestly
go
hold a dialogue with. Because do you believe Black people? Do we go to the doctor?
Not as much, and certainly
How often should we be going to the doctor? In your opinion?
It depends on your age, but around once a year is good.
Once a year at least.
If you're healthy. If you're healthy, if you're 19, 21 years old and you're healthy, don't have a problem, once a year.
Once a year.
But make sure who you go to you trust. If you don't trust them, why would you trust? I mean, you need to find somebody you trust. Once you find somebody you trust, ask that person to vet the information, and you vet the information again, and then go with that decision.
Why is trust important on both sides in terms of people having full disclosure? Which I don't know. Do you feel your patients tell you everything that's wrong with them?
I feel like they do pretty good. I try to make a connection with my patients. I think we do pretty good because that's the focus. And if you're focused on going in and spending your 5 minutes so you can get your money, then you can't do that. Right. Your focus has to be on establishing those relationships, and it does help you long term. So that's critically important. As a physician, you can't do your job, and as a patient, you can't get the appropriate health care unless you're divulging all the information. Same thing with the physicians, and the physicians are at fault too because we don't tell people everything. You go home, I give you something, and then something happens, and then it's like, well, why didn't you tell me that?
Right.
Both ways. Yes, sir.
Dr. Watts, man, it's been amazing. I thank you. It's been an amazing, whole hour, and you succinctly, concisely answered each of my questions, and I think the audience will benefit tremendous from them. It'll be great to see how you're going to do with the panel coming up. They're going to be a little rougher on you, bro. But
we look forward to it.
Definitely. So I look forward to the next couple of days, man. Let's go and let's get the panel going. Thank you again so much. And as I always say in closing, woke to the past. Stay woke to the current. Right? Stay woke for your future. Help me, help you. Unfuck America, my brother. Let's go. Thank you so much, Dr. Watts. Have an amazing
I appreciate the opportunity,
time.
brother.
Thank you so much. Have a great holiday. Thank you.
You too, my friend. You too.
Thank you.
Talk about trust. You're looking at that tug of war. So, do I trust the science because they're telling me this is what's going to help me, but I have a lived experience that says that this may not be so because I have been deprived of other things.
The Pettigrews come from a place of experience professionally and personally. Both lived and worked in Tuskegee for a time. Both are participating in a COVID-19 vaccine trial currently underway. And the couple is advocating for trust in the science behind a vaccine.
We thought that it was important to make this contribution and to represent the community that we're part of in a way that says you can do this and you can take this vaccine.
Was there any hesitation at all?
I had no hesitation. I see what happens when people of color are not included in studies. And that is the downside of it.